tēnā koutou katoa. Welcome to day 21 of lockdown. Yes, I'm counting. Tonight we're lucky to have Murray Hart, who works as a clinical nurse specialist in cardiology at Christchurch Hospital with us. His daytime role includes CCU, cardiology ward and the cardiac cath lab. His focus includes nursing education and cardiology research. Murray's webinar this evening is based on cardiovascular disease and COVID-19, including where have all the heart attacks gone, which should be very interesting to hear about. During the presentation, feel free to ask questions using the Q&A tab, which we will give to Murray later on. And as I say, there's also the chat function just to introduce yourself and where you're from. So without further hesitation, I will now hand you over to Murray. Thank you.
Thanks, Catherine. So as you can see, my surname sort of matches my specialty. And I don't know how many others that are listening that have a surname that matches their specialty, but I've been in cardiology now for about 20 years and it is my passion. So welcome to everyone. So this evening we're broadcasting from Christchurch and this is our teddy bear from our front window as part of the teddy bear hunt. He's now got a mask on more recently. So thank you everyone that's joining us now. And we've got a really interesting hour ahead. So one of the things that I want to cover, first of all, is COVID-19 and the impact of cardiovascular disease on that. I want to go a little bit beyond COVID-19 because I suspect many of the people listening this evening, I suspect the majority of you will be females, and I wanted to just take this opportunity to explore some of the cardiovascular risk factors that affect females and males, but just look and see how these risk factors impact especially on females. And I've really just teased out the three biggies, and the three biggies for tonight are going to be diabetes, hypertension, and smoking. One of the other things we're just going to have a little look at is ischemic heart disease in women, and a really interesting phenomena, and I don't have the answer to this question, but where have all the heart attacks gone? We're seeing it in New Zealand, Christchurch, and all around the world. So we'll tell you what's happening there. There's also an interesting link between lung disease and heart failure that I'd like to share with you, and also heart failure and female comorbidity. I'd like to share a little bit about pregnancy because that's a risk factor that's unique to females and how that impacts on cardiovascular disease. And also a really interesting condition that we're learning more about that's called spontaneous coronary artery dissection. It sort of mimics acute heart attack, but the risk factors are pregnancy and high blood pressure. So we've got lots to share in this hour. So we'll kick off. And one of the things that we now know with COVID-19 is that if people have pre-existing cardiovascular disease, it does increase both the morbidity and the mortality of people that get COVID-19. So that's one aspect of it, but the other aspect too is that people that get COVID-19, that can also by itself cause cardiac problems. So we're going to have a look at both sides of the equation. So these are the comorbidities that increase the risk of dying if someone gets COVID-19. So the top three are cardiovascular disease, diabetes, and chronic respiratory disease. And I guess we've heard quite a bit about pre-existing respiratory disease, but really what tops the list in terms of the highest mortality risk for people that get COVID-19 and are going to die is if you've got pre-existing cardiovascular disease. 10% mortality risk if you've got that in the background. Diabetes is pretty close behind, 7.3%, followed by chronic respiratory disease, which isn't unsurprising. Cancer is a little bit beyond that, and if you've got no comorbidities, you've got a far less chance of dying. So really cardiovascular disease is the highest comorbidity that you can have in terms of increasing the risk of dying from this. Interestingly enough, and I can't explain it, smoking doesn't seem to increase the risk of dying if you get COVID-19. You'd sort of maybe expect it would because it's all related to respiratory disease, but it doesn't seem to increase the risk of dying. So really, we've said that the presence of underlying cardiovascular disease means you've got the highest risk of dying. So therefore, we consider anyone with underlying cardiovascular disease at being particularly at risk of mortality. Out of your whole group of patients that you might have that have got COVID-19, people that have got underlying cardiovascular disease are your most at risk group of patients. They did a study, and some of these studies are starting to emerge now. So this was one that was done in China. It was a meta-analysis, so 8 different studies, over 46,000 people. And the most common comorbidities reported were high blood pressure, hypertension, diabetes, and cardiovascular disease. They were the most common comorbidities associated with people getting COVID-19. So pre-existing respiratory disease didn't actually feature in the top 3 for this study. So this is really hot off the press. How does it compare to New Zealand? Well, this is risk factors identified for people having cardiac surgery, heart surgery around New Zealand. And the big 3 risk factors for people presenting with cardiac surgery are these 3 things here. High blood pressure, hypertension, once again, that rears its head, diabetes, and being a current smoker. So of all the people that have heart surgery in New Zealand, 64% have underlying hypertension. So it shows us it's a real risk factor for lots of things, followed by diabetes, followed by being a current smoker. So this is sort of New Zealand data just for cardiac surgery. It's interesting, if people get COVID-19, they can also present with cardiac presentations. And what people are presenting with all around the world are heart failure or impaired left ventricle function. They present with arrhythmias. They present with ECG changes. They present with raised troponin levels that are indicative of cardiac or myocardial injury. And they also present with raised BNP levels. And BNP, remember, is the little hormone, it's the little protein that's elevated when people have heart failure. So COVID-19 can also cause cardiac presentations. All of this data I'm presenting just came out in the last week, just over a week ago, from the Cardiac Society of Australia and New Zealand combined. So they put a consensus statement out, and some of this is what I'm sharing with you. So it's really hot off the press in the last 10 days, really. So one of the things that we're seeing all around the world, China, Italy, Europe, UK, is that when people get COVID-19, they often present with an elevated troponin. And so normally in our little world pre-COVID-19, we say that anyone that presents with an elevated troponin, they're having a heart attack, and that's still some of these people are. But what COVID-19 seems to also cause is a viral infection of the myocardium. We call that myocarditis. And it's highly likely that the virus itself causes myocarditis. It can also cause just inflammation, and that may be not necessarily due to the virus itself, but just part of the immune response to people getting the virus. The elevated troponin may also be due to Takotsubo syndrome, that's broken heart syndrome. So that's a syndrome that happens that mimics acute myocardial infarction. It's pretty unique to ladies and also post-menopausal ladies. So that can be in response to emotional stress. and also physical stress. So we're sort of seeing an emergence overseas, particularly of ladies that are presenting with Takotsubo, but the trigger for it is COVID-19, and they may not necessarily have COVID-19 themselves, but just the stress associated with it all. We also know that when people develop multi-organ failure, they develop hypoxia, and that hypoxia causes an elevated troponin. And I guess we're familiar with scenes all around the world of overrun intensive care units, people developing multi-organ failure, and as part of that, they also have troponin elevation. And of course, we also know that sometimes people get elevated troponin from other body systems, and so people that develop acute respiratory infections, they also have an elevated troponin. It doesn't mean to say they're having a heart attack, but it's part and parcel of injury to the myocardium. So one of the two big things really are elevated troponin and myocarditis. So if you are dealing with patients that are probable or definite COVID-19, you should be measuring a troponin. Expect it to be elevated from any one of these causes and be on the lookout, especially for myocarditis. So the big two things, elevated troponin I or troponin T and myocarditis, seem to be the two cardiology presentations that COVID-19 causes. Its impact on the heart. You know, in the early stages of COVID-19, we've believed that it's all about the lungs. But you know what we're learning, and certainly literature that's coming from overseas helps us to appreciate that maybe it's lungs, and heart. So it's still lung comorbidity and impact on the lungs is a major impact of COVID-19, but we shouldn't ignore the impact on the cardiovascular system. We shouldn't ignore the impact on the heart. So there are people that end up with serious cardiac consequences of COVID-19 in addition to the lungs. So it's not all about the lungs. 1/3 probably is to do with the heart. So we're learning lots. And in the news also there's been some talk about unique treatments for COVID-19, and one of them is chloroquine. And I read a little bit of literature from one of our respiratory physicians, and certainly the studies that are suggesting that chloroquine is effective in COVID-19, these are studies they've suggested that would normally not be published. They don't have a lot of scientific evidence behind them, but sort of in the hype, the media hype of today, any little study sort of gets published. And so there's not a really evidence yet to suggest that these treatments do work for COVID-19. And really just a word of caution in terms of chloroquine for COVID-19, some of these treatments do also impact on the heart. So these can cause cardiac toxicity, they can prolong the QT interval, and that can present with cardiac arrhythmias, and they can build up, they can become toxic, especially if people have pre-existing liver or kidney dysfunction. So just a word of caution really with some of the treatments that really aren't evidence-based yet, and also just to remember that they do have cardiac consequences by themselves. So we just have to be careful about the cardiovascular implications of some of the treatments that might be being touted as cures for COVID-19. One thing I think we are realising, even in New Zealand and certainly Australia, even though the impact has been less, is we have had to prepare for healthcare delivery that's quite different from normal. And so some of the things that we have done even in Christchurch and many of the tertiary hospitals around New Zealand and Australasia, is we've changed our threshold for admitting people. So we are only admitting people that really need to be admitted and need cardiac monitoring. It's been suggested that maybe we should even utilise thrombolysis more than acute angioplasty. PCI is the terminology for percutaneous coronary intervention. So that's putting a stent into coronary arteries. That's sort of the gold standard, but there has been suggestions that maybe if our cath labs get overrun, or to protect our cath labs from becoming too infected, maybe thrombolysis may have a greater part. We haven't seen that yet, but we have increased the number of thrombolysis files on our shelf. A big thrust is getting people home quicker, so rapid discharge pathway. So we're now doing much more earlier discharge for people that have had non-ST elevation myocardial infarctions. We're doing same-day discharge for people that have had angioplasty and stenting. And we're managing people more as outpatients, maybe for things that before we might have admitted people. So an example of that is people that have chest pain, but they're troponin negative. So for high-risk people, we might admit them. Our threshold for admitting people is much higher now. Maybe for non-life-threatening arrhythmia like atrial fibrillation, we see atrial fibrillation everywhere, don't we? We see it in rural areas. We see troponin negative chest pain in rural areas. So those groups of people, we're sort of wanting to keep at home more, and you may well be managing them in your practices rather than admitting them to hospitals. There's been even suggestions that our coronary care units might be overrun by people needing non-invasive ventilation, CPAP. That hasn't happened yet, but overseas, I guess we've seen what happens when intensive care units get overrun, and that goes down to our coronary care units, because in our CCUs, we're very used to managing non-invasive ventilation. So it is a pool of beds that could be used for non-cardiology presentations like COVID-19. So different sort of a way of working different thresholds. And it's been suggested that as we go forward, some of what we do now may well continue in the future. And some of the early discharge and same-day discharge that we're practicing the last couple of weeks, I suspect we're going to keep on doing them. It sort of works well to get people out sooner. And maybe it's been a little prompt, some of the pathways that we've been doing, and we've said, oh, well, if we can bring this in the next 5 months, we're doing pretty well. 6 months to a year is things happen slowly, don't they? But they've all of a sudden, they've happened in 1 to 2 weeks. So we brought in 2 same-day discharge pathways within 2 days. Normally, it would take us 6 months to do that. And I suspect some of these things we may continue to adopt going forward. And so we do have to be adaptable, and we have to be very versatile. And it's really forced the issue for many of us. I'd like just to leave COVID-19 just for 10, 15 minutes. And I'd just like to explore cardiovascular disease in general. And I'd like to suggest that cardiovascular disease isn't equal between men and women. So a lot of the risk factors are the same. But for females, these risk factors that we are familiar with, some of them are more prevalent in women. Some of those risk factors carry a greater magnitude of risk for females compared to males, and some of them are absolutely unique to females, and one of them is pregnancy. So males don't have that risk factor. So we're just going to go through some of the risk factors that are present between males and females. But I'm not going to go through all of them because it would take the whole time, but I'm going to tease out probably the important ones that we've talked about in terms of COVID-19. So we've said that with COVID-19, one of the cardiovascular comorbidities that seems to influence mortality is diabetes. So when we compare a female diabetic with a female non-diabetic, the female with diabetes has a 3 times higher risk of having an MI, so much more at risk. When you compare a female diabetic with a male diabetic, your female with diabetes is more likely to have a myocardial infarction earlier, and if they have a myocardial infarction, they're more likely to die compared with a male diabetic. So diabetes is one of these risk factors that both men and women have. But if you've got a female patient with it, or you're a female and you've got diabetes yourself, it does have a greater magnitude of risk compared to if you don't have it, or comparing with a male. You know, in general terms, anything cardiovascular is approximately twice as bad if you've got diabetes. So that applies to coronary artery disease, anything cardiovascular. So just a general rule of thumb. So in your rural practices around New Zealand, if you've got a patient and they've got diabetes, the cardiovascular impact on your patient will be worse, twice as bad, in fact, compared to if they didn't have diabetes. So that's something that affects us all, because I think all of us in our practices around the country look after diabetic patients. The other risk factor that we've talked a bit about already this evening is high blood pressure. And you know, I'm going to talk even more about it. And females are sort of protected from high blood pressure because of estrogen, premenopausal. But what we see is that once females become post-menopausal, the incidence of high blood pressure goes up. So over the age of 60, there's a big increase in high blood pressure. So you should be on the lookout for this in your rural practices. You should be aware of it. We also know that females that have got high blood pressure, it doesn't seem to be as well controlled compared to men. Why is that? Don't know. But your female patients, they may well have blood pressure that's worse controlled than your male patients. You know, we had some new guidelines came out 2 years ago. The Hart Foundation put them out. And it's pretty scary. They said that the ideal blood pressure for most people is likely to be less than 120/75. You know, the bar gets lowered and lowered and lowered. And when you're next back at work, I'd like you to get one of your colleagues to do your blood pressure. That's our homework from tonight. We should all know our own blood pressure. You know, one of my colleagues offered to do my blood pressure at work last week, and I won't tell you what it is, but I don't fit into guidelines. And so we should all know what our blood pressure is, because it is a risk factor for us all. But I'm going to share with you as we go on, especially for females, high blood pressure is a killer. So, you know, these new guidelines that came out just 2 years ago, they said that we should be doing lifestyle modification if your blood pressure is 130/80. You know, we used to consider that normal blood pressure, didn't we? But the bars become lower. And this is incredible. If you work out what your 5-year cardiovascular risk is, and we've got these nice calculators, haven't we, that work that out. So if your 5-year cardiovascular risk is greater or equal to 15%, and your blood pressure is greater than 130/80, we should be adding medication. Amazing, isn't it? I'll tell you what high blood pressure is like. It's like a vice going on the heart. The heart muscle, the myocardium, has to pump so much more harder to get the blood out And over time, over years, it'll weaken the heart muscle and it can lead to heart failure. And I'm going to share just a little bit later one of the types of heart failure that we see, and one of the risk factors for it having high blood pressure, and especially for females. So your homework, remember, in the next week, get somebody at work to measure your blood pressure. We should all know what our blood pressure is. The other third main risk factor I wanted to just talk about is smoking. So smoking, we know, is a cardiovascular risk factor for both men and women, but it seems to be a greater risk factor for females compared to males. We've said before that estrogen sort of protects females, but if you've got a female smoker, that estrogen protection sort of is negated, it's taken away. For whatever reason, I can't give you a reason, nicotine sort of is metabolized faster in females. Some of the risk for a female smoker is so much greater compared to a male smoker. So if you're a female and you're a smoker, your risk of having a heart attack is 3 times more compared to on non-smoking female. Your risk of having a heart attack, you're more at risk of having a heart attack 19 years earlier. That's almost 2 decades earlier. And much, much higher risk of heart disease compared to a male smoker. So smoking for females is one of those risk factors that's greater for a female than a male. This is from the Heart Foundation website this year. So if you've got a female patient that you look after in your practice and they're a smoker, they're 3 times more likely to have a heart attack than those that don't smoke. So within our practices, within our rural practices, who are your at-risk groups? So your at-risk groups are especially your Maori women and also your Maori men. But Maori women, females, they're the most, they've got the highest percentage of being smokers. And you know, also those adults that live in socio-economically deprived areas are more likely to be current smokers. So where are our socio-economically deprived areas? Many of them are in our rural areas. Northland, where Catherine works, it's where you've got your highest percentage of Maori smokers and socio-economic deprived areas. So many of you in your rural areas are working with the most at-risk patients in terms of smoking. These same guidelines a couple of years ago said that we need to begin screening even earlier for our at-risk group of people. And the people that the populations that they identified were our Maori population, Pacific Island, South Asian populations. We should begin screening for 30 years for men and 40 years of age for females. That's a lot earlier than Europeans. So normally we say for Europeans, men, we should begin screening at 45 years of age, females 55. So be aware wherever you work of your at-risk group of patients. Current guidelines. You know, this is from Australian stats, but I suspect it's probably pretty well much the same for New Zealand. They say that 90% of females have at least one risk factor. If you do your blood pressure within the next week and your blood pressure is over 120/70, you've got a risk factor by guidelines. Scary, isn't it? You know, many of you will know where this fountain is. This is in Wellington, isn't it? And to me, it's like a little picture of risk factors. So you might get one risk factor and it's like that little bucket at the top. It's just a small amount of water. But then you add a second risk factor and you add a third risk factor and bang, the impact of that is much more significant. It also is a picture to me of pathophysiology. pathophysiology. You know, with pathophysiology, one thing leads to another, and then it all cascades with illness. And maybe in our current environment, that big blue bucket down the bottom, maybe that's COVID-19, that's the big fear that none of us want to have. But, you know, if you go right up to the top, some of these other little buckets might be a bit of cardiovascular disease, it might be a bit of high blood pressure, might be having a diabetic, might be smoking, might be a bit of pre-existing respiratory disease. Things by themselves maybe don't carry that much risk, but once you combine risk factors, it has a much bigger magnitude. So to me, this is just a picture of risk factor multiplication, and it's also a wonderful little picture of pathophysiology for many of the conditions that we deal with in our daily practice. You know, I was over in Queensland the other year, and I travelled to and from the Gold Coast every day for a few days to a cardiology conference. And one of the things that really struck me was as the trains came into the station, they said, coming into the station, Brisbane station, mind the gap. And what they were telling people to do was to mind that tiny little gap between the train and the platform. And I mean, I certainly wouldn't, I'm not that thing that I would fall down that gap, but many people might trip over. And so the warning was just mind the gap. Don't just, this tiny little gap, but mind the gap. And you know what, I took a message for that for my practice, because in my practice, we have to be aware, and in your practice, we have to be all aware of patients that can fall through the gap. And you know, some of the patients that are most at risk of falling through the gap are our female patients. And one of the groups of patients, female patients that can fall through the gap really easily are those female patients that present with myocardial infarction. And the reason that they can fall through the gap and be missed is because females often experience more non-cardiac chest pain than men, and they have different symptoms. And any group of people that have different symptoms often get missed, and they fall through the gaps. And in your rural practices, people can fall through the gap. And also in our big emergency departments at tertiary centres, patients can fall through the gaps, and female patients fall through the gaps. So we know that females sort of present a lot more subtly with heart attacks compared to males. Males tend to be more dramatic, and when they first present, it's a full-blown heart attack. They get crushing chest pain. Females have this sort of that they have more subtle symptoms, and those symptoms can go on for weeks even before they present with a heart attack. And you know, when you're seeing people in your rural settings, whether it's in the home or in GP practices, medical practices, or whether it might be in your smaller rural hospitals, we can very easily send female patients home by mistake. And so we just have to be really aware of this group of people. So these are all symptoms that females have that males often have less often. And by themselves, you wouldn't necessarily relate them to cardiac presentation, heart attacks, but they are red flags. And one of them is really interesting. Often female patients, when they have a heart attack, they have numbness or tingling in their hands or arms. And it's another thing I can't explain. There's lots of things I can't explain, but that just seems to be one of the features. Another thing that I can't explain, and I'm honest here, is that often with female patients, they have this really strong prodromal fatigue, unusual fatigue. And I'm sure many of you in the audience now, you'll be feeling fatigued. You've done a day's work like many of us here. You're feeling tired. So are you having a heart attack? I hope not. But what patients tell us is this fatigue is far worse than normal. So this unusual strong fatigue is a prodromal or a lead-up sign to often female patients having a heart attack. So remember, any patient that presents atypically, diagnosis is delayed, and if diagnosis is delayed, treatment will be delayed, and if treatment's delayed, well then outcomes are worse. And I'm going to share with you shortly, outcomes for female patients having a heart attack are worse, and that's one of the reasons why. You know, if you've got a female and they're diabetic, you know what we call them? We call them double trouble. And the reason for that is we've just said females often present atypically, but also our diabetic patients can present atypically. So diabetic patients can present with silent ischemia. And if you've got silent ischemia, it's really, really easy to miss a cardiac presentation. So just be aware in your practices if you've got female patients and they're also diabetic, because they may present atypically. So just remember some of those symptoms that we have talked about. We've also looked at shortness of breath, chest tightness, chest pressure, some of those symptoms that are less dramatic than males, but can be cardiac presentation. One of the things that we know through literature is that females often wait longer than males before calling for help. We also know that sometimes some of the tests that we do, like exercise treadmill testing, that they maybe are more likely to be a false positive or even negative for female patients. We also know that even as health professionals, we have biases. And so sometimes we expect females not to have heart attacks. And so we triage them or prioritize them differently to males. So we have to be really, really careful in our practices that we aren't displaying a gender bias. Female patients do worse than males. And you say, why is that? And it's a very good question, because we have very good guidelines to show that we should treat men and women the same, but females do worse after a heart attack, and yet the guidelines are the same. But I suspect it's all to do with delayed diagnosis. So if there's a delayed diagnosis, female patients do worse. So we know for a fact, this is New Zealand data, that more females will die within a year of heart attack compared to males. The treatment should be the same, the guidelines are the same, but often it's due to delayed diagnosis. You know, what's really, really interesting is one thing that we've seen overseas and also in New Zealand is since we've gone into lockdown, we've had a dramatic decrease in the number of heart attacks. You know, we have data that's produced every single month for us, and so this tracks the amount of people coming into Christchurch Hospital every month since March 2017 through to current, for those people that come in with a non-ST elevation myocardial infarction. So you can see numbers per month usually vary between 40 to 60 every month, but something's happened right at the end here in March 2020. All of a sudden, numbers have dropped to less than half. And so so we went into lockdown, when was it? Was it the 25th of March or something, I think? Something like that. And in the lead up to that, there's restrictions. So in those 2 or 3 weeks of March, we've seen a huge reduction of heart attacks. It's all to do with lockdown. What about admissions for ST elevation myocardial infarction? Since the 25th of March to today, we've only had 15 for and this isn't a full month yet, but certainly the previous month we had 26. Looking overseas, Italy reported a reduction of ST elevation MI by 70%. In Washington, a dramatic decrease. Other places, Atlanta, reduction by 20 to 50%. So this is a huge reduction in heart attacks we're seeing. So the obvious question is why? So here's our cardiology ward. This has been empty for 2 weeks. This is a 30-bed cardiology ward, completely empty. So we've got about 4 6-bedded rooms. They're all empty, completely empty. This ward has been closed for 2 weeks. I've never seen the ward closed in the 21 years that I've been working at Christchurch Hospital. Amazing. This is data that we see every day for our Christchurch Hospital wards. And I've never seen the hospital at 47% capacity. So every day, our capacity of our Christchurch Hospital doesn't get above about 55, 56%. And that's because we're not doing elective admissions and we're getting people out sooner and not admitting people. Every time you see a little blue dash, this is an empty bed. Normally we would be up about sort of 80 to 90% capacity. So we've got a huge capacity in our hospital every day to take COVID-19 patients, and that's why we're doing what we are doing, because we want to have capacity, but those numbers haven't come. Currently in Christchurch Hospital we have 1 confirmed patient, and the amount of probable cases sort of varies between about 15 to 20. So we've got a wonderful capacity available to us. So the obvious question is, why aren't people having heart attacks? Well, we don't know, but possibly it's been suggested that maybe older people are staying at home, and if their symptoms aren't too bad, then they're not calling an ambulance. There are a lot of patients that are afraid to come into hospital because of COVID-19. You know, just before I finished at work, I was talking to a patient, and his wife especially is terrified that he's going to come home with COVID-19. His wife maintains a really, really strict bubble. And so a lot of our patients are terrified, our elderly patients are terrified, so they're staying away from hospital. Maybe there's less heart attacks because there's less work. So there's less work stress, and maybe even driving to work stressful. You know, one of the things that we do see in cardiology is some people have heart attacks and they also have cardiac arrests at the gym. And I wouldn't ever like to suggest that gyms are bad for us, because they're good for our cardiovascular health. But we also do see people have heart attacks, MIs, STEMIs, out of hospital cardiac arrests when they're doing a workout or just finishing at the gym. And so I don't think we've seen 1 out of hospital cardiac arrest from the gym since we've gone into lockdown. So we don't know. We have to learn more about this, but what we do know is that the data shows us huge reductions. And so we are doing things differently. In cardiology, we're doing less stress testing, we're doing less echo, we're getting people home shorter, as we've said. One of the things we don't know either is what effect is it going to have deferring elective procedures. So we've stopped all our elective angioplasties, we're putting people off. So what's going to happen in the future? Will these people present acutely with acute heart attacks? Don't know. We hope not, but we may well see a second wave of people presenting acutely because we've put them off. We're organising our teams differently. One of the things that we've also seen is far less transfers from rural hospitals. So we're keeping people in rural hospitals, and many of you that work in rural hospitals will be seeing the effect of that. You'll be looking after people that you wouldn't normally be looking after. Everywhere you see a Red Cross is where we have a 24-hour cath lab available, and there's lots of other cath labs around the hospital that don't run a 24-hour service. And many of you that work in rural hospitals won't be able to transfer people following heart attacks to these centres unless they're really urgent. So you're dealing with patients that you wouldn't normally be dealing with. Let's just talk briefly about the lungs, because the lungs do impact on the heart. And when people have lung disease that impacts on the heart, we call it cor pulmonale. So cor pulmonale is right heart failure caused by lung problems. So here's the link, here's the lungs here, and here's the right side of the heart here. So when this fails, there's often a bit of back pressure. So there's a very close relationship between the two. And you say, well, what causes lung problems? Well, we see these things commonly in our practice. We see COPD, we see people with pulmonary embolus, we see high blood pressure in the lungs. These are the things that impact on the heart, especially the right side of the heart. So COPD is all to do with little changes in the alveoli sacs, remodeling, inflammation, all goes on in these little air sacs. But it narrows the little blood vessels and it impacts on the right side of the heart especially. So the little blood vessels that lead to the heart become very narrow, and that puts back pressure onto the right ventricle. And so we see people developing with heart failure, mainly affecting the right-hand side of the heart from long-standing lung disease. So it all happens inside the little arterioles that lead to the lungs. But it impacts on the right ventricle. So it's heart failure impacting on the right ventricle. Do these people exist? They do. Here's an echo report. And the summary says this person's got severe high blood pressure in the lungs. What's the cause of it? A dilated right ventricle. This little figure here shows that this person has a normal pump function for the left-hand side of the heart, but the problem is all in the right ventricle, and that's caused back pressure affecting the right side of the heart. So the two are very closely related, heart and lungs. You know, there's a brand new type of heart failure, and it is linked to some of the comorbidities that we've talked about with females especially. Some of the older classifications are right and left heart failure, and also heart failure that's caused by an inability of the heart to pump. We call that systolic heart failure, and an inability to relax. We call that diastolic heart failure. But you know, there's a whole new classification of heart failure, and it's based on the ultrasound or the echo of the heart, and we call it the ejection fraction. So the ejection fraction is the amount expressed as a percentage of what the heart pumps out in one beat. So the new classification of heart failure, we divide people according to what their pump function is. So if you've got pump function less than 40%, we call it heart failure with reduced ejection fraction. And if you've still got pretty normal pump function, we say heart failure with preserved ejection fraction. You know, the group of people that have heart failure with a fairly normal pump function are females. And the comorbidity that's driving this is high blood pressure, obesity, atrial fibrillation, diabetes, coronary artery disease. So these are all cardiovascular comorbidities that we've been talking about. And they cause damage within the cells, within the myocytes, and it causes heart failure. You know, the buzz terminology for this is HFpEF. So a HFpEF is heart failure where you've got normal pump function. A HFrEF is when you've got reduced ejection fraction. But what we're seeing is that older females are more prone to this when they have this cardiovascular comorbidity. So we're learning that if you've got an older female patient and they've got cardiovascular comorbidity, and remember the comorbidities that we looked at before, high blood pressure, obesity, diabetes, atrial fibrillation, this will lead to heart failure. So here's a lady, a 40-year-old lady that we had. She's got normal pump function with the left ventricle, But down here, it says that she had severe diastolic dysfunction. So she had normal pump function, but her heart wasn't able to relax. So she had heart failure with a preserved ejection fraction. You know, this particular 40-year-old lady had obesity. She presented with a blood pressure of 200, so she had hypertension. And you know, the sad thing was she died within 6 months. So here's a 40-year-old lady that died of heart failure. And what was the cause of her heart failure? It was comorbidity, cardiovascular comorbidity. So we do really have to treat high blood pressure as a killer. Just going to skip through some of these things. Pregnancy. You know, pregnancy we consider a stress test for the heart, because the whole metabolic system's revved up, isn't it? Some of the things that we're learning is that some of the complications of pregnancy, having preeclampsia, low birth weight, preterm delivery, stillbirth, that carries cardiovascular risk. And that cardiovascular risk makes itself known before menopause. And we're really only learning the full significance of the complications of pregnancy. But it's been suggested that pregnancy complications may serve as one of the earliest clinical markers for future cardiovascular disease in women. You know, this was on the Ministry of Health website just a few weeks ago, that pregnant women appear no more susceptible to the consequences of COVID-19 than the general population. You know, that's been removed from the website. I looked again just 2 nights ago and I couldn't find it. So I don't know whether they've changed their stance on this. I do know that there's understanding that maybe early pregnancy and later pregnancy might be the more important part. So I'm not an expert at this, but this has now been removed from the Ministry of Health website. So possibly pregnancy, we're learning in terms of COVID-19, may well be more important than they originally thought. If anyone's got anything to share on that, please feel free to share it. Just in the last 5 minutes, because I just do want to allow 5 minutes for questions too, there's an emerging awareness of a disease that we call spontaneous coronary artery dissection. So what's going on here is there's a little tear inside the blood vessel, the artery. And so this is dissection, not occlusion with a blood clot. You know, when most people have a heart attack, there's a blood clot that forms and it blocks the artery, whereas this is a tear inside the artery, but it causes a very similar presentation in terms of chest pain compared to someone having a myocardial infarction. So it's not a buildup of cholesterol, it's a tear or a dissection in the artery. So here's the tear here, compared to a narrowing that causes a problem with a heart attack. So totally different pathophysiology. Here's an angiogram picture. This little black line here is what we see when we take people to the cath lab, and that's typical of a little tear in the artery. You know, these are the way that people present with that. They present with chest pain. That chest pain radiates to the arm, and they often have nausea or vomiting, the 3 most common presenting symptoms. You know, if you saw these 3 in anyone, you would immediately probably think cardiac STEMI or heart attack, wouldn't you? But these are how people with spontaneous coronary artery dissection also present. But you know, it gets even more interesting. The people that mainly are at risk of this are those that have hypertension. So this is rears its head again. It seems to be the risk factor that we keep on coming back to, especially for females. Emotional stress, reported in almost 50% of the cases. Who's under emotional stress at the moment? Everyone. 30% reported physical stress, and that physical stress was actually lifting quite heavy weight. So over 23 kilograms of weight seemed to be significant in one study. What's really interesting is the link to pregnancy. So early pregnancy and also later pregnancy, and in that early postpartum pregnancy is where the biggest risk factor seems to be for females. And I suppose in later pregnancy, there's more blood volume, so more cardiac output, more stress on the coronary arteries, more stress on the blood vessels, and that's probably why at this stage of pregnancy females are more prone to a tear in the coronary arteries. I'd encourage you, if you are looking after in your practices anywhere a pregnant lady, late pregnancy, early postpartum period, and she's got chest pain and she suggests it might be indigestion, I think you should do an ECG, because it's really easy just to dismiss it as indigestion associated with pregnancy. But on our radar should be spontaneous coronary artery dissection. So just be aware, and often it happens in females that are otherwise healthy, thin, and no risk factors. So no other red flags apart from the fact that they're complaining of indigestion late in pregnancy. I think we should sort of never dismiss it as indigestion. We should be safe and do an ECG. We treat it with beta blockers and we avoid putting stents in. So the learning point from spontaneous coronary artery dissection is that it is an unusual cause of people presenting with acute coronary syndrome, but we should be aware of it in a differential diagnosis when we're assessing people with chest pain, especially young, healthy females. So just be aware of it as we go forward. One of our cardiology registrars, the poster boy for the Hart Foundation advertising campaign this year, and we're sending him over to Vancouver to learn more about it. So in conclusion, really there is a difference in cardiovascular disease between men and women. Some of the risk factors are the same, but in females it represents a higher magnitude of risk. And remember, patients with pre-existing cardiovascular disease are more susceptible to mortality if they get COVID-19. So remember, it's not all about the lungs, and the lungs. It's about the lungs, and the heart. And our challenges in tertiary hospitals is still to give attention to really urgent presentations. So we've got to maintain good services for the people that need it the most. And those people are the people that present with ST elevation MI. Stay safe. I'm very happy to take some questions in the last few minutes.
Oh, that was wonderful. Thank you very much. You're so enthusiastic as a speaker, eh?
Oh, that's my passion. That's my passion. Yes. And thank you for everyone for listening to share my passion.
So no, what people were saying about how interesting it was, and that that was the 26th that the lockdown did actually begin on.
Yes.
I think you've given me a wonderful reason never to go to the gym again, just to protect my heart. Thank you very much.
If you want an excuse, this is it. It doesn't get any better than this.
And so here we go. So I've got relating to the nicotine. If someone is now not smoking but is on NRT, is their risk the same as if they were smoking? For someone who is on NRT gum long-term due to addiction?
Yeah, so the risk definitely does go down once you stop smoking. So the biggest risk really relates to the smoking. I mean, it definitely it reduces risk.
Should we be treating the PHT more aggressively, and should we be using Viagra more often for this?
Yeah, it's a very good question. So we know that pulmonary hypertension is a nasty disease. We generally sort of reserve sildenafil to once people advance in the disease. So our starting medicines are usually calcium channel blockers, and we often do testing in the hospital just to see how responsive people are to that in terms of lowering pressures. One thing we don't know is just the right combination of medicines and when we should actually add sildenafil. Sildenafil is a very good medicine. It's a very good vasodilator. I suppose we have to be careful in some cases, but yeah, I mean, I think it's a very good comment, and sometimes we maybe institute some of these additional therapies later than we should, probably because we don't know the right answer. There's no evidence that just tells us what is right for any one person at any given point and what the ideal combination. We know that often combination therapy is good between sildenafil and bosentan. Just when that right time is, we guess a lot of the time, I suspect. So very good comment.
Yeah, it is. And then we've got, why do we screen women from an older age when women's risk factors are multiplied?
Maybe gender bias, do you think? It could be. I suppose we know generally that females are protected to some extent from the estrogen. So once they become post-menopausal, that's when some of these risk factors begin to be multiplied. So for instance, hypertension, the incidence of that does increase. So there is some assumption that I can see your cat in the background just walking past, Catherine. That there is some degree of protection, but yeah, you're absolutely right. I think we do need to get a more aggressive with risk factor modification. I mean, we do tolerate high blood pressure too well. How many people do you measure their blood pressure and they're not on guidelines? And we say, oh, well, you're just a bit above. And so we do tolerate it. And you're absolutely right, that multiplication factor, risk factors, I think we tolerate too well.
And then we've got another one here saying, fantastic presentation. Is dependent edema, puffy ankles, always related to right ventricular failure?
Yeah, so it's a very good question. So the answer to that is no, it's not. So people can have other causes of peripheral edema. I mean, there can be problems with vascular drainage. So if people have got vascular problems, that will also result in edema. Some of our kidney failure people can have low albumin levels, for instance. So anyone with low albumin is more prone to interstitial edema, and that does accumulate more in the dependent areas. So it doesn't always relate to right ventricular failure. I guess some of the other clinical signs that we look at is raised JVP and ascites. So it's really just one piece in the jigsaw, but it is an important clinical sign, but there's often other information we need as well.
And then we've got Emma says, does troponin I tend to be elevated in the SCAD similar to its classic MIs?
Yeah, good question. So it does. Yeah, absolutely right. And we do see ECG changes. So we see symptoms, raised troponin, and ECG changes that are all the same. So what is maybe slightly different is sometimes the troponin rise isn't as high as you might see with a full-blown, not non-STEMI. So slightly older women, like females 50, 60, that have just maybe a troponin rise of a few hundred to 1,000, like a little red flag. So, but you're absolutely right, it does elevate the same as an MI.
All right, here you go, one sentence answer. No, I'm kidding. In a nutshell, why is diabetes such a major risk factor for CVD?
Yeah, so it's the impact on blood vessels in particular. So for coronary arteries, the coronary arteries tend to be much more narrow and smaller, and therefore more easier to block. So it does sort of promote damage within coronary arteries more so than if they don't have diabetes.
And we've got why beta blockers for SCAD? Would it repair the tear eventually?
Yeah, so the main indication for beta blockers is to lower the blood pressure. So most of these people, females and also males that present with SCAD, have high blood pressure. So the beta blocker is really to lower the blood pressure. The artery wall just heals itself if we leave it. But to prevent it from happening again, recurrence, beta blockers are all about high blood pressure management.
Okay, so in rural primary care, do we start adding hypertensive meds early with female, or add health promotional advice, e.g. weight loss activity?
Very good question. I mean, I think we should always look at lifestyle modification first, and if that doesn't work, then look at pharmacology. I mean, we've got, and you've got little risk calculation guides which will tell you the impact of a lifestyle modification on things like cholesterol. And often you can achieve the same reduction in cholesterol by lifestyle modification as to medication. So first up, really, I think for borderline people would be lifestyle modification. Good question.
And then we've got, how often should calcium score on CT angiography be repeated?
That's a very good question because I don't know the answer to it. But I suppose in general terms, what the calcium score is reflecting is atherosclerosis or disease. We know for some people, atherosclerosis disease can be really rapid, and even in 6 months, atherosclerosis can get worse. I suppose through statins, we try and slow that process down. I mean, CT angiography does carry risk, so there's radiation and there's also contrast. So, I mean, if to say how often should we repeat an angiogram, we tend to do it only if symptoms recur. So it probably shouldn't really be repeated on a regular basis in any case. If people got symptoms, again, it might be reasonable to do it, but I don't think there's any time factor that I could think of that should be repeated routinely just because of the associated risks.
So we've got, does one see the same levels of BNP in systolic and diastolic heart failure?
Yeah, so it's interesting. Often BNP doesn't go up as much with diastolic heart failure. The other situation that BNP doesn't go up as much in is people that have got raised BMI, so obesity. So yeah, definitely diastolic heart failure or the heart failure with preserved ejection fraction and obese people, you don't get the same increase in BNP.
I'm just trying to go through the chat as well.
Yes.
We've got questions coming in 2 angles here. So we've got, is cardiovascular symptoms one of the screening questions presenting patients are being asked prior to going to red or green zones and EDs? If they could be a sign of COVID, I'm not working in that area. So I think they're wondering about how we're screening it, do you know, in terms of symptoms maybe? I was trying to figure.
Yes,
exactly what I'm trying to ask.
so I suppose we tease out, I mean, it's all part of good history taking, isn't it? And for any admission, a cardiovascular history is important. And so from the history, we often get the red flags to explore other things, don't we, in terms of physical examination too. And our history also guides what tests and investigations that we choose to do. And it also guides and sets our differential diagnoses. So as part of really good history taking, cardiovascular history should be taken. And I guess as part of that, risk factors should become apparent. Definitely, if you suspect that someone has got COVID-19, then a cardiovascular history is very important. Yeah, hopefully that answers the question.
I think so, and Diane's also said that she's working in the CBACs, and so it's worth always taking the history and just flagging if the patient is moderately to severely unwell.
Yes.
I think is sort of up the same avenue, really.
Yeah, and is it Diane that's given me an answer for the diabetes, that epithelial inflammation is what does the damage, so thank you for that. Yeah, and that definitely impacts on the coronary arteries too. One of the things that we do know is that inflammation increases the risk of plaque rupture. So if there's plaque and you've got inflammation going on, you're more likely to have a heart attack, so that probably feeds into that too.
And so carrying on down in that question and answers now, we've just got the comment around I'm surprised we're not seeing any more of the SCAD. Are non-STEMI patients staying away from hospital? Are people scared to come in even if they have symptoms?
I suspect the answer to that is yes. I think that people are too scared, even if they do have symptoms. And I suppose we do know that elderly people especially are very stoic. I think unless symptoms are really severe, people are actually staying away. They are terrified of getting COVID. You know, I was talking to a patient yesterday and I offered him a patient education sheet to take home to his wife, so a little piece of paper like this, and he wouldn't take it home to his wife because he's told me his wife would not allow it into the hospital at home because it had come from the hospital. She's terrified that he's in hospital for one night tonight with us. So there is a lot of fear, and maybe that's also why people with SCAD aren't presenting at the moment too. It's that same fear, I suspect. But we'll probably never know the extent of it.
We've got Deb saying, do you think we're on a movable trajectory for CVD management, e.g. outpatients for angiograms and COVID-19 environment?
Yeah, that's a very good comment. I think we are. I think we are. We're definitely in a movable feast at the moment. Things are changing week to week. And yeah, I think, yeah, I mean, we at the moment, we do angiograms as day cases, you know, frequently. I suppose what's slightly different is we're discharging non-ST elevation people pretty well the next day. STEMI's 2 days, unheard of. So this is definitely a movable trajectory, absolutely.
Okay, thank you. And then there's one question. Oh, here we go. We may see patients with COVID coming in later with heart failure the next wave post-lockdown.
Yes, I agree. So Maxine, I work with Maxine, and yeah, I agree totally. So we maybe will see, we haven't seen a lot of it yet, but what we may see more of is late presentation MI2. And definitely if people stay away and they have their heart attack at home, what they will present with probably in the next wave is heart failure. So these are the things that'll be really interesting to track through. I suppose we get some of our clues for what we might experience from overseas literature, and that's certainly coming through now. It helps us to prepare for what our trajectory might be also.
Oh, well, I think you've survived tonight through New Zealand. Well done.
Yes, thank you very much. Thank you very much to everyone that's still online and listening. Thank you for sharing my passion. And yeah, maybe 6 months' time, if we repeated this again, we'll have different, well, probably even a month's time, won't we? There's just so much coming out all the time. So thank you very much too for your facilitation, your moderation, Catherine. Keep up the amazing work that everyone does all around the country.